Okay, let me see. So thank you very much. I have exactly 20-minute video, so every second that I'm speaking now is going over. So thank you very much. Let's begin. So the purpose of this talk is to teach, especially for younger surgeons, how to do a proper exposure for skull-base surgery. It's a little bit different than doing for endoscopic sinus surgery. So I'll go through my technique. First, good decongestion in the United States, we use cocaine. Here it's not possible, so I use oxymetazolam and sometimes injections. But we need to do a complete, this is on the right side. Most surgeons are right-handed, so we use a two-surgeon, but right side is the primary approach side. And we must do a complete anterior-posterior ethmoidectomy on the right side in order to gain proper access. My preferred uncinectomy technique is using the pediatric backbiter, first an incision high and then an incision low. And if you have a shaver, it's very useful. Is it possible to turn the lights down a little because it's hard to see the video? Can we turn the lights down? I think that's better, huh? Good, okay, let's restart. Oh, thank you. Okay, we'll start again. So I'm holding the septum back. See, if you hold the septum just with a Freer's elevator for some time, it gives you just enough time to get in there and do what you need to do anteriorly. It's not a good idea to do a septoplasty when you're doing endoscopic skull-base surgery because you're going to remove the posterior half of the septum. And if you also do a septoplasty, making incisions in the anterior part, you're going to end up with a high chance of perforation. So you should avoid septoplasty, even if you have to struggle to do your uncinectomy. Once you're past the uncinectomy and anterior ethmoidectomy, you have a nice open clear space to work. But don't do a septoplasty, okay? Now I'm doing my uncinectomy with a pediatric backbiter. If you purchase a backbiter for any sinus surgery, it's very important to only get a pediatric one, very small. The larger backbiter is just too big to get in and do a proper uncinectomy. If you have a shaver, you should then do a complete uncinectomy. You should do a complete ethmoidectomy because you don't want to cause postoperative sinus disease from incomplete ethmoidectomy and get obstruction on that basis. So now here you can see even I cracked the bulla while doing the uncinectomy with the backbiter. You should do that. There's no reason to struggle and avoid the bulla. Now you also have to do a very large maxillary antrostomy because I'm going to create a flap from the middle turbinate and you need somewhere to place that flap while you're doing the surgery. So you do a very nice maxillary antrostomy and take that flap down. Now look, now I'm going along, you can start to see the roof of the skull base. I'm working with a 0-degree endoscope. You want to go and do anterior, posterior, go through the ground lamella. Once you've completed and gone through the ground lamella, here we can see the anterior ethmoidal artery along the skull base. You want to see your landmarks clearly, not to cause complications from avoiding them. Once you complete here you can see the posterior ethmoidal artery. So we know we're along the skull base. After the anterior posterior ethmoidectomy, we're going to demucosalize the middle turbinate. Now you see I'm taking out the mucosa of the posterior ethmoids. Unlike chronic sinus disease, you want to demucosalize the posterior part of the sinus cavity because for healing purposes, you want scar tissue to form. I take a shaver. It's much easier with a shaver to demucosalize the lateral or internal part of the middle turbinate. You can do this with a cold steel method, but it's a little more time-consuming with a scissor. Once I demucosalize it, then I detach it from the roof. I'm using a left curved septal scissor so that the tips don't point up through the skull base and are much safer to use. When I get to the back, Sorry, I didn't touch anything. I can go forward here. Can you go forward a little more? Oh, back a little, back. Back. That's good. So now I've taken the septum down and I've put it into the, I've taken the turbinate down and I've put it into the maxillary sinus. Now we're going to make a septal flap. I use a 2-flap system to get much better coverage and to give yourself a lot of room. If you sacrifice one middle turbinate, it does not affect the patient's airway or breathing. Now I take a septal flap, and this mucosal flap is pedicled on the sphenopalatine artery. You don't need to take as large a mucosal flap if you also take a turbinate flap, which preserves the anterior portion of the septum, which is the most important part for comfort and breathing and healing. So now I first make an inferior incision along the floor, and I just come up to where the middle turbinate was, just deep to the attachment of the inferior turbinate. I make a superior cut, and I don't go all the way up to the top to preserve the olfactory system. You should stay a few millimeters from the top, and as you come more anteriorly, you should come down, okay? Because they're more important in the anterior part. There's no olfactory fibers in the very posterior part. And then I make a vertical incision after making the other 2 incisions, and then we'll elevate this flap forwards. Now, I use this a caudal elevator. It's a nice sharp elevator to preserve the mucosa, and then also to take the bone and preserve. Here you can see the you can see the perichondrium here, okay? We're going to basically be exposing the bony portion. You want to leave the cartilaginous portion alone. Once we go all the way to the back, it's also very important to detach the Okay, I'm sorry, I didn't touch this at all, and something is starting and stopping the film. Okay, thank you. You can go a little forward. Okay. So, yes, let's go. This is good. We'll start here again. So we want to elevate this flap and take the mucosal flap off of the bony septum. Once we've got it back, it's very important to detach the inferior posterior attachment, because if you don't adequately detach the back end in the choana, you won't be able to rotate it up. So you have to be very careful, and very careful not to cut through the vascular pedicle of the sphenopalatine artery. So now we're going to start here with this incision. You see, I made sure I was in the choana. I could see the nasopharynx and cut down. We're going to come forward now. And as I said before, you come up forward to the front of where the inferior turbinate is, but no further, because you don't need to elevate it much further than that. Okay, now we're elevating it, just making a plane straight to the perichondrium. And in some patients, they have had prior septoplasties, so you have to work a little bit to separate this, not to completely go to the other side, but it's not a problem if you go across to the other side for the breathing, only that you won't have, if you have a mucosalized substance on the other side, it won't stick. So you have to make sure that you have something that's not mucosa, because you want it to heal. Now I'm separating it very carefully. You see here, this is the back inferior aspect of the flap. I want to make sure that it's completely separated. Now we're going to follow the flap up. So as we follow the flap up, you're going to come across the front face of the sphenoid sinus. Watch. So we're going to detach it from the top with a scissor, couple of cuts, and then you're going to come all the way to the front face of the sphenoid. You know, we use navigation because it's a skull-based procedure, but I rarely even look at it, because if you really learn your landmarks intranasally, you can do a lot. You don't have to look so much at navigation. It's not necessary. In many countries, we don't use navigation for pituitary surgery. So right here, we've entered the sphenoid sinus. You can see that that's the front of the sphenoid sinus right in the midline. This is called an aquamantis. It's available in US, also available in EU. It's a little expensive, but it's an excellent, it's a bipolar basically on a stick with a self-irrigator. But it is a little expensive. It's not absolutely necessary. Now, we're going to then follow this flap over the front face of the sphenoid. You see, so this takes us into the sphenoid, and as I elevate into the sphenoid, we're going to come to here the natural ostium of the sphenoid. Okay? Now watch here. I'm going to elevate this out, and you have to cut and separate this from the natural ostium of the sphenoid sinus. Otherwise, you won't be able to pull the flap down. Right there is the mucosa. Right here is the natural ostium. And you can see there's a little mucosal pedicle. This mucosa is actually going into the sphenoid. So you want to come across that and separate that, and then put your flap down into the nasopharynx. I like to put it down with the non-mucosa side facing me, always the same way, because at the end of the procedure, it's sometimes difficult to tell which side is which. It all swells up and it's hard to differentiate. So you should put it in a way that you know which side has to go back up. So the next landmark we're going to look for is the sphenoethmoidal recess. And I'm opening now. Here is the posterior ethmoid artery. Here is the sphenoethmoidal recess. This is the sphenoethmoidal recess is the connection of the front wall of the sphenoid sinus to the skull base, the lamina papyracea at its posterior extent, and the skull base itself. Okay, now I have the posterior part of the septal bone. You can see my incision was made right where the bony septum began, okay? And you want to take this out for reconstructive purposes. So we're going to take this out. We're going to expose the mucosa on the other side. Here's the cartilage, right, the back of the cartilage. And we're going to leave this intact because we are going to open it later, but we're not going to open the whole thing. We're going to minimize what we need so we have very good anterior nasal anatomy. You know, if you preserve the anterior aspect of the nasal anatomy, they don't have symptoms afterwards. So here's a nice big piece of bone. If you can't take that, or they've had revision, if it's a revision surgery, the front wall of the sphenoid sinus is also a nice piece. We call it the keel. It looks like the keel of a boat. You can crack that piece off and use that for reconstruction also. Now, once I go through, I'm going to take a shaver and go through the back of the septum to the other side, and this is the superior turbinate. So the first landmark is to go through the superior turbinate, and then we're going to do a posterior ethmoidectomy from the opposite side, okay? And it's very safe if you have nice landmarks established from your first side. If you fail to identify the limits of the right side, you'll have more risk on doing this relatively blindly on the other side. Save any piece of cartilage, any piece of bone you have. Now look, see, here is the front wall of the sphenoid. Here is the sphenoethmoidal recess. I'm reaching only as far as the opposite side, so I'm using this as a visual landmark, and I'm doing a posterior ethmoidectomy to the other side from this approach. And doing it gently, of course, and you can feel your limits, and you want to crack that open just enough. And here, now I'm just going to clean up enough septum to stop a little bit before the cartilaginous portion. You can see here is the middle terminate on the other side, okay? So we're going to leave the middle terminate on the other side intact. We use that for, you know, just for humidification. We don't want to remove the middle terminate on the other side. And we also leave the middle terminate on the other side available for any future procedures and or repairs of CSF leak. So we have something still nice. Again, this is the back of the cartilage. I'm getting hemostasis. You want to nicely get hemostasis with some kind of bipolar on this edge of the septum because that's what bleeds during the procedure, and the blood runs right down your endoscope during the whole procedure because you have a lot of instruments in there to work. You have to take the mucosa out of the sphenoid sinus completely to avoid mucocele formation. So check your CT scan to see how extensive. Sometimes you have extensive mucosalization deep into the roots of the pterygoids. So I'm removing all of the mucosa. Okay, so now on the opposite side, you just want to lateralize the middle turbinate because we're going to work on the inside, okay? We're going to work medial to the middle turbinate. If you have to do some ethmoidectomy to get some room, that's fine. But usually it's enough to just gently crush the ethmoids laterally. Now, I'm going to go back in here, and we're going to drill the rest of this to get a nice exposure, okay? The remnants, I did all of this first with the hand instruments, and now we'll use powered instrumentation. This is very important. Don't go higher than 35,000 RPM on your drill, even if it goes up to 80 or whatever. If you go too high, it's just going to spray water all over, and you won't see anything. So I found that 35,000 is a good speed to be able to work. You see, I have no suction in there. I just pulled back my view a little bit. I'm getting a little bit of snowflakes on the end of the scope, but enough to be able to work. Also, look, I'm drilling from the inside forward. If you drill the opposite way, you can catch the sphenopalatine artery and destroy the blood supply of your nasoseptal flap. So just gently put the drill. You don't need larger than a 4 millimeter or smaller than a 3 millimeter. Most of the procedures I do just with a 4 millimeter diamond burr. 3 millimeter if we really have some very specific type of a tumor other than a pituitary where we have to delineate some structures carefully. So I only buy a medium grit 4 millimeter and a fine grit 3, and that's it. Smaller than that is not practical. Now, you really want to see the very top of the plenum sphenoidale, okay? And you want to look, here is your optic canal, here is your other optic canal, here's your sella, here's your carotid canal, and your carotid canal, okay? Now, you want to check your landmarks, check your navigation, or your visual landmarks, check your imaging. The biggest risk here is drilling into the carotid artery, probably more likely than injuring an optic nerve, because the optic nerves actually, they don't come to the center. They actually, as you get more posteriorly, they go more posteriorly. They stay away from each other. But the carotid canal is the vulnerable spot. So what I do is I don't try to drill completely through to the dura. I just try to score it. And then if you crack it, you can then crack it. You've made a little score marks. Stay away from the edges, and then you finish it with a kerosene rongeur. And when you take the kerosene rongeur, pull forward. Make sure that you don't have any extra tissue, because that's where you can grab a piece of the carotid artery. So just make sure you seat your rongeur as forward as possible before you close it. If you've made it very thin and flat, you can fracture off the rest. And I want to point out some areas. Up here you have something called a circular sinus, and you sometimes have to bipolar that. It bleeds, so when you make an incision, don't make your incision at the top, otherwise you'll have a lot of venous bleeding. Also at the very, very top here, there's a little area of arachnoid that comes down. There's a little depression there. So you can get a little micro CSF leak if you open the bone too high to the top. Okay, you want to open it all the way to the top, but you want to be a little limited in how you do it, just so you don't get a little CSF leak there. Now, we're opening up the dura after bipolaring it. And then in this particular case, this was a hormone secreting, I believe it was a growth hormone secreting tumor, so it wasn't very large. But here, I'll show you in a minute, my colleague and I, we got a little CSF leak here, just from being a little aggressive in pulling this piece, okay? So it's not a big deal, and I chose this case particularly so I can show you exactly what to do. The first thing you need to do is you need to suction the CSF until the level of the CSF goes down enough for you to be able to work. because you can't work underwater. So just wait patiently and let the CSF come out. Okay, so now the CSF is out. And then you're going to look here. We're near the end of the resection because you can see right here, this is the normal pituitary. The normal pituitary has this kind of bulbous orange appearance. Sometimes on the MRI, often, you can see it, unless it's a very large tumor, and you cannot. Now, when there's a CSF leak, I put a little fat flat down, not a lot. You don't want to fill the sella with fat. And then I take some bone, and then I just wedge it in somehow. You don't have to make a perfect fit. See, just so it stays. You don't want to push it so high that you're pushing against the optic nerve, and you don't want to fill the sella. But it's enough to hold this in place. I don't use any artificial tissues. I fill then the entire sphenoid with fat. I also fill the sphenoid with fat even if there's no CSF leak. And the reason is that it gives you the best reconstruction of the anatomy of the posterior aspect of the nasal cavity. Because if you don't do that, you'll end up with a big shelf there. And also, if you have to do a revision, it's very difficult to take these flaps off of that dura. It's really almost impossible. So here you can see, now I'm taking this septal flap, checking my side. This is the mucosa side. And this shorter version of the nasoseptal flap goes nicely over to the patient's left side. And then I take the middle turbinate flap out of the maxillary sinus, and I'll put it over the right side. So you'll see that 90% of this defect is covered. And look, we're coming almost to the back of where our septum is, so we have only a few millimeters of gap from the very back of our septum to this reconstruction. So you minimize crusting and accumulation of debris and cleaning by using this two-flap method. So here I pull this, you leave some bone in. So basically this acts as an osteoplastic vascularized flap. So you've got bone in, and you've got mucosa outside. And now you can see I've covered it, try to pull it up, and try to get it up as high as possible. The next step is also very important. Forget about dissolvable packing. This is a gimmick that a lot of people use just for like a sales technique. Say, oh, I won't pack your nose. Okay, don't pack the nose. You'll have much bigger problems post-op with healing and crusting. You have to pack the nose. I put a silicone airway in each side of the nose. That goes down into the nasopharynx, cut about 1.5 centimeters off of it, because otherwise it'll be too low. And you put the pack over the silicone airway. And look at this. This is 1 month. No debridement necessary, okay? I take these packs out before they go home, usually 3 days, 5 days if they have a lumbar drain. And then they go home, and I see them about a week after they go home just to take 2 big clots out. And if you see them again a month after that, they have no crusting. So it's a very, very nice technique. If you don't use this two-flap technique, you'll have a lot of crust, and you'll have to debride them forever. That's what I have. If you want to take a quick photo of this, you have all my contact information from that QR code. Thank you very much.